So now we're going to talk about diffuse prostate cancer, and diffuse prostate cancer is understandably one of the more disconcerting forms of prostate cancer that we see in my clinic. Diffuse prostate cancer looks a little bit like this, and what it basically refers to is disease that's spread through numerous regions of the body. Diffuse disease can develop after failed treatment of localized prostate cancer, for instance, after prostatectomy or radiation therapy, or it can appear de novo, okay? To assess diffuse disease, you typically need to undergo a PET scan. You also need abdominal or pelvic MRI to look at diffuse disease. And the reason this is extremely important is because some patients will have disease that is in the liver. We call this metastases to the liver. Metastases to the liver typically will indicate a very difficult form of prostate cancer to treat, and we like to know right off the bat if a patient has disease in the liver. Another thing that I think has to be assessed at the very beginning is the kidneys, or are the kidneys. It surprises me how many patients come to me who are receiving advanced treatment of prostate cancer and their kidneys are blocked. And this is a tragic situation because you need your kidneys to be able to fight the battle against prostate cancer as you move forward. So you want to ensure that the kidneys are draining and functioning adequately so that you can go on and be treated for your prostate cancer. So you need to get abdominal pelvic MRI or CT to assess for these things at the beginning. Likewise, you need a biopsy, and the biopsy is to assess not the diagnosis of prostate cancer, but what types of cells are present in your prostate cancer if you have diffuse disease. One other thing that I advise is patients should get genetic testing to determine if they have inheritable forms of prostate cancer or prostate cancer associated with BRCA1, BRCA2, or other mutations. And the other reason we get genetic testing is to assess for microsatellite instability or tumor mutational burden, because these things can be used to determine if you can treat a patient with various forms of immunotherapy. So I break diffuse disease into two different forms of cancer. I break it down into uncomplicated diffuse prostate cancer versus complicated diffuse prostate cancer. So the difference is if you have prior systemic therapy or if you've had prior systemic therapy, it's complicated. If you have unfavorable genetics in your blood testing or your tumor testing, that's complicated. If you have bad cell types present on your biopsy, that's complicated diffuse prostate cancer. If you have an unfavorable ratio of PSA to metastatic burden, then that's complicated. And finally, if you have unfavorable disease distribution, for instance, in the liver and so forth, that is unfavorable disease. I'm going to talk about unfavorable factors for a while because they're all related to each other. So we're going to talk about that a little bit because all of these subjects are interrelated. When you talk about prostate cancer, it is not one cell. I already pointed out it's very heterogeneous. And even when you look at the best form of prostate cancer, adenocarcinoma, it is also heterogeneous. Adenocarcinoma is generally a good form of cancer to have if you have prostate cancer, because generally speaking, it has androgen receptor, which makes it susceptible to hormone therapy. And it has the serum marker PSA, which comes out in the bloodstream. And it has the marker on the surface, which can be imaged and targeted with therapy. However, with adenocarcinoma, you can have good stuff or you can have bad stuff. So Gleason 6, adenocarcinoma of the prostate, pretty friendly stuff, relatively speaking. Gleason 10, adenocarcinoma of the prostate, typically bad cell type. A lot of times by the time you're getting to Gleason 10, you're starting to lose hormone sensitivity, the androgen receptor, and you're starting to miss out on the expression of some of these markers, such as PSA and PSMA. A bad cell type is something like neuroendocrine small cell tumor or neuroendocrine prostate cancer. Neuroendocrine cells do not have androgen receptor. They are not sensitive to hormone therapy. These guys are bad, and they typically constitute around 5 to 7% of prostate cancers that are diagnosed. These cells under a microscope tend to look more like nerves than nerve cells rather than prostate cancer cells, and they make things that you find in nerves, such as synaptophysin, neuron-specific enolase, chromogranin A. So these are bad cells. They do not play well, and they're difficult to treat. Another thing that's really terrible to see in a biopsy is small cell or unclassified prostate cancer. I call these ugly, the good, bad, the ugly, Clint Eastwood, right? These are ugly cells. These are very, very, very highly aggressive. The reason you have to know about this is because cells like Gleason 10 or neuroendocrine or small cell, they make very little PSA, very little PSMA. They can grow like wildfire, but you can have a very low PSA in the bloodstream. So you can have a low bloodstream PSA or low serum PSA, but huge amounts of cancer inside your body. So these are all examples of patients that walk through the door to see me. They have a PSA of 0, and they're literally head to toe filled with cancer, prostate cancer. This person is riddled with prostate cancer. This person has all kinds of lymph nodes in the chest. This guy has a tumor the size of a football growing in his chest, PSA 0. In fact, 12% of our patients with undetectable PSA in my clinic, 12% of them will in fact have metastatic disease. And this is why PET scan is so important, because if you just go by the PSA, you would not pick up these patients. So now we're going to talk a little bit about prior systemic therapies, how prior systemic therapies can make prostate cancer management more difficult or complicated. So when we talk about systemic therapies, we're talking about hormone therapy, Lupron, Eligard, Zoladex, Firmagon, bicalutamide. When we talk about prior therapies, we can also talk about chemotherapy, Taxotere, Gevtana, carboplatinum, other forms of therapy, Zofigo, which is radium-223, 177, PSMA, lutetium, Lynparza, olaparib, Rubraca, etc. We also talk about prior therapies in the form of second-generation hormone therapies, Zytiga, Xtandi, Erleada, Nubequa. These are relatively new drugs that are very, very popular. We're going to talk about this form of prior systemic treatment and how we believe it complicates the management of advanced diffuse prostate cancer. These drugs are very, very popular, and I think sometimes these drugs are being used a little bit too much and without much thought. Zytiga, abiraterone, Xtandi, enzalutamide, Erleada, apalutamide, so forth. These drugs are very tricky to monitor, so you have to know that if you're on these drugs, you better have your ears pricked up because there are things to watch for. Specifically, we have seen that patients that are placed on these drugs will see a decline in their PSA, but in fact, if you run them through a scanner, the cancer gets worse. In fact, we have named this paradoxical responsive therapy. So the PSA is going down, the doctor tells you, you're doing great, everything's going great, but then you run them through a PET scanner and you see the cancer is growing. So this is something that you have to watch for. In fact, we looked at a series of patients and we're in the process of publishing this. 20 to 40% of our patients on these drugs will exhibit a paradoxical response to therapy. In other words, PSA will go down, but the cancer will keep growing. So this is something that everyone should be cognizant of. Another issue that I have with second generation hormone therapies is, the typical reason for using these agents is, well, they're not as bad as chemo. But these drugs also do have some side effects, and I wouldn't say that the side effects of chemo are necessarily worse than the side effects of these drugs. I mean, all drugs and all therapies have side effects. So I wouldn't use that as justification for using these drugs over chemotherapy. We don't know this for a fact because our data is retrospective, but we do have some suspicions that these agents may inadvertently compromise overall optimal outcomes. Our residents and fellows several years ago looked at the data at Mayo Clinic, and this is what we found. Patients who have hormone-resistant disease have two options. They can be treated with chemotherapy first, and then second-generation forms of hormone therapy, or they can be treated with the second-generation hormone therapy first, and then chemotherapy. The blue line on this graph basically depicts patients' survival if you start with second-generation hormone therapy first and then try to get chemo. Based on our retrospective study, it seems that survival is not as optimal if you start with these convenient oral drugs prior to receiving chemotherapy. It seems that patients that get chemotherapy up front actually may do better than patients that start with these oral drugs. However, I have to remind you, this is retrospective data. Side-by-side kind of clinical studies have not been done in a prospective randomized trial. So we interpret all of this data with caution, but these are things that we need to be concerned about. Related to that, I've also seen that with patients who fail these drugs, I have personally seen that it's very difficult to treat these patients with chemotherapy after they fail their drugs. A lot of times standard chemotherapy doesn't cut it. You have to use something stronger in order to cause the disease to regress. So why on earth would this be the case? Well, my theory or my inference is that some of these drugs, whether it's second generation hormone therapy or even prior chemotherapy or hormone therapy for that matter, sometimes these drugs will cause initial regression of disease. But as we know with cancer, if you don't get it all, something grows back. And typically what grows back is probably a selected or induced form of bad prostate cancer. So basically with some of these drugs, they're not mean enough up front. They let something slip through, and what comes back tends to be very aggressive and tough. I do want to mention two pet peeves that I have, given the fact that I see about 6,000 patients annually. I do not like it when patients come to me with advanced disease, very often terminal advanced disease, and they've never been offered chemotherapy. I think that that's not good. I think that patients, when they are healthy enough early on, should be offered chemotherapy because chemotherapy is very effective for treating their prostate cancer. Another thing that kind of irritates me is when a patient has been given a couple very minimal treatments and then are randomized or placed on clinical phase 1 or phase 2 trials. A phase 1 or phase 2 trial is not a replacement for thinking smartly and treating the cancer aggressively with current powerful treatments for prostate cancer. So these should not be used in lieu of excellent treatments for prostate cancer, okay? Now I'm going to talk a little bit about genetic testing and how that reveals some bad features of prostate cancer. We use circulating tumor cell methods to look at genetic testing of prostate cancer. And we do this after each and every form of systemic therapy. So if you've done Taxotere recently, we check the genetics afterwards. If you then failed Zytiga, we check the genetics afterwards. The reason you check the genetics after every form of systemic therapy is because, like I said, the cancer mutates. And you want to look at what is the most recent mutation so that you can treat the cancer with the best agent possible. We typically avoid using original specimens. I have lots of patients that come in and they say, well, you know, I'm on my 4th treatment And now my doctor is looking at my prostate specimen for 20 years ago. I'm not sure that the original specimen is as relevant to the genetics of the cancer as here and now. So typically, we do not look at original specimens for genetic testing. The point of genetic testing is to find BRCA1 and BRCA2 mutations that might be treatable by PARP inhibitors such as Lynparza, olaparib, or Rubraca, which is rucaparib. Also, when we do genetic testing, we're always looking for microsatellite instability as well as high tumor mutation burden, because these can be treated very effectively with checkpoint inhibitor immunotherapies, such as nivolumab, Opdivo, pembrolizumab, Keytruda. And nowadays, insurance recognize the fact that if you have high microsatellite instability and high tumor burden, you might be a good candidate for treatment with these excellent drugs. So for uncomplicated disease, meaning no prior therapy and no bad indicators, typically when I see a patient with diffuse disease, I advise hormone therapy throughout, combined with chemotherapy in the form of Taxotere or Jevtana sometimes, which is cabazitaxel. Usually chemotherapy is given once every 3 weeks. Each time you get it, it's called a cycle. We typically ask for 6 cycles of treatment, but we always check patients after the 3rd cycle just to make sure that the hormone therapy and the chemotherapy is working. Nothing's worse than going through 6 cycles of chemotherapy and finding out nothing is happening. When we assess patients, we repeat blood testing and we repeat PET imaging for these individuals. Usually afterwards, if there's a residual PSA on these individuals, we then use 2nd generation hormone therapy, Xtandi, Zytiga, Erleada, and darolutamide. These are great drugs, especially in terms of polishing off residual disease. Afterwards, we'll take a look at the patient and we'll also decide, is there a role for surgery or what we call consolidative radiation therapy to kill off whatever is left behind. And we think that whenever possible, this is a very important step, because even with all of these therapies, achieving a perfectly sterile environment with all of these forms of therapies is very difficult. But if you then put on top of it consolidative radiation therapy or consolidative surgery, you might get a better outcome and actually clear the disease. For a simple hormone-resistant prostate cancer, of course, these patients stay on hormone therapy forever. They get chemotherapy in the form of Taxotere, assess at 3 cycles, like I said before. Then we use 2nd generation hormone therapy after chemotherapy. And then once again, we look for the possibility of consolidative radiation therapy or consolidated surgery to wipe out whatever might be left behind. If you have any of the bad features that I talked about that make it complicated diffuse disease, our thinking almost immediately starts to shift. We start thinking about some form of chemotherapy that has platinum as a component of treatment. So Taxotere plus carboplatinum times 6 cycles, Jevtana plus carboplatinum times 6 to 8 cycles, sometimes even cisplatinum with etoposide for anywhere to 6 to 8 cycles of treatment. And of course, these patients stay on hormone therapy. The reason we think about platinum is very effective against resistant or hardened or aggressive forms of prostate cancer. And I've actually been very, very happy because I've seen in the community more and more and more people talking about treatment with carboplatinum. At some level, I think that many medical oncologists are already recognizing that platinum-based chemotherapies may have some advantages over and above what taxane-based chemotherapy provides. So we treat these patients with the chemo, we assess as we always do. Then we treat these patients with 2nd generation hormone therapies. And then also we look for whether or not there are mutations that can be treated with a PARP inhibitor like Lynparza or Rubraca, or immunotherapy like Keytruda or Opdivo. And then at the very end, once again, we look for chances of consolidation with either radiation therapy or surgery. Now, I want to make it very clear that these algorithms that I just covered, these are our bias or opinions within my clinic, but there is no gospel in terms of treatment. This is just what we think works based on our experience within my clinic, okay? So now the next question, of course, there's this new technology right around the corner, 177 PSMA lutetium. Question is, where is that going to fit in? Where is it going to fit in? So, of course, you're saying, well, I'll tell you where it will fit in if you tell me what the heck you're talking about, right? So 177 PSMA lutetium is a form of isotope that can target cells that have PSMA on their surface. Like I showed you, some cells have PSMA on the surface, and you can get a PSMA PET scan. This gentleman clearly has many, many tumor cells that have PSMA on the surface of the cell. If you light up a PSMA PET scanner, then by definition, you may be a candidate for treatment with 177 PSMA lutetium. 177 PSMA lutetium works like this. The lutetium binds to the PSMA on the surface of the cell, and the surface actually gets irritated a little bit like Dr. Moyad gets irritated when I talk too long. So then the 177 PSMA lutetium gets sucked up by the cell and ingested. And then it gives a burst of beta radiation that kills the cell as well as all cells around it. This is very interesting because it starts out as a specific therapy for PSMA positive disease, but it also kills PSMA negative disease. And then these cells die. It is associated with relatively few side effects, and it can be highly effective. So here's an individual that was treated with 177 PSMA lutetium, dramatic reduction in PSA, dramatic reduction in number of tumor cells with the cancer. And this is a killer. It kills cancer cells. It's expected to be approved by the FDA in 2021 or 2022. So that's very, very soon. It will be approved for patients who have failed hormone therapy as well as chemotherapy who have metastatic disease. In order to qualify, though, you have to have a PSMA positive PET scan. But mind you, 10 to 20% of patients will not have PSMA on the surface of their cancer. So right at the start, there are going to be patients that are not going to be eligible for treatment with 177 PSMA lutetium. Thus far, based on the Vision trial, which was published, about 50% of patients experienced greater than a 50% decline in PSA. We do not know thus far what the durability of treatment is. When I eyeballed the treatment of my patients, we probably put somewhere between 80 to 120 patients onto the Vision trial within Mayo and through collaborators. When I eyeballed what happened to the patients, about 33% of the patients had a great response to therapy. 33% had a mixed response. About 33% probably had no response whatsoever. We don't know how long these responses are going to last, but based on what I've seen so far, I think it's a lot like other forms of therapy. You get good responses, but it by itself is not going to rid the patient of disease completely necessarily. So my summary of 177 PSMA lutetium thus far is it's an incredibly cool, very good treatment for prostate cancer, but it is not a miraculous fix-all. I think we all have to remain realistic about the fact that it is a new, wonderful treatment, but it has to be used judiciously. Once again, after all forms of therapy, you need regular follow-up This is imperative for life. You should get PET scans, PSA, MRI, and whatever. My final thoughts are that I think it is imperative nowadays for you to be your own greatest advocate for your own cancer. Doctors are busy. They're not bad people. They're just busy. And a lot of times they don't have time to explain things. And sometimes I just feel that, everyone is so busy that we're not necessarily thinking about all of the issues either with regards to what we're doing, how we're doing it, so forth. I think it's very important that you make every effort to totally understand your disease. It's your disease. You should understand it, and you should try to steer some of your treatments. Do not be discouraged by the unbelievers. There are people that you'll walk in the door and they'll say, "Oh, I can't cure that. You're going to die in 6 to 8 months." Those doctors do not know that for a fact. Okay. Don't be discouraged by those doctors. You may want to kind of maybe pick someone else that maybe is not as much of a Debbie Downer or something like that, but don't be discouraged. There's a lot to be extremely excited and happy about. Try to avoid pitfalls and traps. Use all of the tools of treatment wisely and in the right sequence to the best of your ability. And, as a charge for the future, I think that patients and organizations should be thinking about replacing some of our old technologies with PET imaging for our patients now and in the future. I'd like to finally thank the PCRI for letting me roll out some of my thoughts and some of my ideas so many years ago. I mean, when I first started speaking, we didn't know if some of these things would work out. We didn't know how they would play out. I've been very, very lucky in my career. Many of the things that we rolled out over 10 years ago have now become the cutting edge of what we do for prostate cancer. Concepts like PET imaging, concepts like oligometastatic disease, PSA zero, disease heterogeneity, the idea of focusing on curative as opposed to palliative outcomes. In terms of thanking people, though, the people I really want to thank are my patients, because they tell me every day how this is playing out for them. They share their ideas. They criticize what we do poorly. They say, Eugene, you got to fix this. You got to do this. When a patient comes to me and tells me something, I think that that's a huge privilege. If I were sick, I probably wouldn't want to share very many things with very many people, but I would share things with people that I respect and that I honor. When a patient comes to see me, I immediately feel that I'm in a privileged situation. It's a sacred moment, and I take what they have to say very seriously. And in essence, everything that I've done on this talk and in terms of innovation was given to me by the motivations and by the emotions, the hardship, the heartbreak of my patients. So that's why I wanted to make this talk. I wanted to give it back as a gift to all patients out there that are fighting prostate cancer. And I want to thank all of you for permitting me to be part of your care. And then, of course, I have to thank all my collaborators and my associates. I am really lucky. I've been surrounded by some of the absolute smartest and most talented surgeons and scientists and clinicians on the planet. I'm very, very fortunate in that regard. I'm kind of at a nexus of everything, even going back to my days when I got to work with Jim Allison, who I always said was one of the most brilliant people on the planet. Last time I talked to PCRI, I said I thought that Jim Allison probably win the Nobel Prize, and he did. He did. I'm just lucky to be in the shadows of all these people. So I just want to say thank you to all of you. All right? Good luck. Bye-bye.